Welcome. Thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. Bylaws, Section 14 on committee attendance. If any member of a standing or special committee of the board will not be present at a scheduled committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attend the scheduled meeting and be counted as a member for purposes of quorum and voting. Sally Hernandez Pinheiro has requested that Jackie Rowe Adams be counted for the purpose of quorum and voting on her behalf. That request was approved. And please note for the record that Sally Hernandez Pinheiro is in a listening capacity virtually. So first, I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on January 9th, 2023. I will poll each member for their vote. Jose Pagan?
Yes.
Dr. Katz?
Yes.
Jackie Rowe Adams? Yes. I vote yes, so the minutes are adopted. Next is an action item for consideration. I think Ms. Farag, you're going to read the resolution into the record.
Yes, sure, thank you. Action item, base tactical best interest renewal, authorizing New York City Health and Hospitals Corporation, the system, to enter into a 5-year best interest contract extension with Base Tactical Disaster Recovery, Inc., mentioned as Base Tactical, to provide project management and consulting services for the repair, restoration, and hazard mitigation of system facilities damaged by Hurricane Sandy, with the system holding 2 one-year renewal options for an amount not to exceed $6.8 million over the potential 7-year term. Additionally, to extend the current 2016 contract terms ending June 30th, 2023 to December 30th, 2023 to allow for the expenditure of the balance of $1,407,641.37 for Superstorm Sandy. Okay, so just for a little bit of background, Base Tactical is our disaster recovery consulting firm where we use their expertise in business management and logistical coordination for providing services. And they provide these services since 2008. Their specialty is emergency management, in particular FEMA public assistance grants. And basically what we are utilizing here specifically is their interdisciplinary capacity to provide a package of multiple services that address different areas that include recovery, first response, remediation, and all these components, architectural design. So it's a disaster recovery consulting firm. It was needed due to the administrative complexity of the FEMA reimbursable work and the lack of in-house expertise and resources in the area. Currently, New York City Health and Hospitals has about $1.7 billion in FEMA grant funding for Superstorm Sandy repairs, which has its own allotted direct admin cost dollars called DAC, which we'll go over a little bit later. And Base Tactical also provides services for Hurricane Ida grants development, which is currently in progress. Also has its own DAC. Base Tactical services are funded through the DAC, which is the direct administrative costs. And these are costs that are defined as the admin costs that enable the grant development and grant reimbursement and closeout. The DAC dollars are calculated based on a percentage of the total repair and restoration mitigation dollars, and that's 4%. I will turn over this part to my partner Oscar at the OFT.
Thank you, Micheline, and good morning. So we have a lot of FEMA projects, Sandy projects, as we like to call them, currently that we've completed, that are active, or that we're actually going to continue on. Specifically at Bellevue, we have a grand total of about $498 million of priority mitigation projects that we have completed several years ago, including medical gas systems and flood barriers to our elevators to make the elevators more resilient. Today, we are currently designing with our friends or our with our friends over at the Department of Design and Construction, a community flood wall that's going to run from 30th Street all the way down to 25th Street. And that project's estimated to be $247 million and expected to be completed in 2030. At Kohler Hospital, a total of $180 million went to that facility. Again, primary mitigation projects to the tune of $43 million. And we also are implementing a new generator that's almost complete. And the bigger portion will be a new berm wall that will be completed around the facility to meet the FEMA requirements of the 500-year sea level rising requirements. And that's estimated to cost about $95 million and expected to be completed in 2026. At Metropolitan Hospital, we have a total of $120 million. Again, some mitigation work, specifically critical quick connect projects for a total of $13 million. And we are actively installing in construction a flood wall at the facility now that will meet the 500-year requirement. And that's budgeted for $117 million and expected to be completed next year, December 2024. And at South Brooklyn, a total of $922 million has gone there. A lot of it for mitigation work. We also completed a flood wall and obviously our new building, new permanent mitigation structure known as the CSS, 10-story building, which is almost complete. We have received a temporary certificate of occupancy and just waiting for DOH to perform the final survey so we can start providing services there. And that's all I have. Back to you, Michelle.
Thank you. So we have also utilized Base Tactical for services during the pandemic. So they provided COVID-19 services through an emergency contracting process. Base Tactical provided services to the response and the work that was done with COVID-19 and all the procurement components that we did through the emergency contract. So Base Tactical provided services from the beginning of the pandemic, assisting in grants development and reimbursement processes. And we're basically at this point wrapping up COVID services since FEMA has issued the cutoff date for COVID-19. Just a little table below just talks a little bit or shows a little bit of the dollars that were granted under this emergency contract and the remaining dollars under that piece, which are expected to be completed by the end of the 2016 contract, which is June 30th of 2023. So we are requesting an extension of the existing 2016 contract, which was procured via public RFP. The existing contract expires on June 30th, 2023. OFD and Finance is requesting to extend the term of the current 2016 contract to December 2023 to allow for the spend of the remaining $1.4 million for Superstorm Sandy FEMA work, and also requesting a best interest extension for an additional 7 years, which are 5 years and 2 one-year extensions at $6.8 million in additional dollars. This extension is specific to the work around Hurricane Sandy, so all the Superstorm Sandy projects that Oscar took us through at the following facilities: Bellevue, South Brooklyn Health, Kohler, and Metropolitan. Those will go beyond the 2023 fiscal year through 2030 and potentially beyond that. And there will be additional Hurricane Ida needs that will be covered under this extension. Base Tactical has a 30% MWBE goal on their contract and has achieved 61% to date, so they've met those requirements. In the table at the bottom, it just shows a little bit of how we got to the 1.4 million that we requested the 6 months term extension for, and also shows the new contract request for the period of 7/1/23 through 6/30/2030 of 6.8 million. So when requesting a best interest extension, we have two things that we're covering: the pricing due diligence and the vendor due diligence. For pricing due diligence, the FEMA consulting fees are, as we mentioned, reimbursable by FEMA, and to be reimbursable by FEMA, they must meet their price reasonableness guidelines, which they have. These guidelines include fees by resource type, task, and time billed for the task by the appropriate resource. Base Tactical was one of the early consulting firms that specialized in FEMA reimbursement. The market has grown with traditional consultants without this level of expertise and multifaceted experience for those who entered the field. The rates charged with Base Tactical met the price reasonableness, again, for the guidelines of FEMA that they apply across the industry. Our grants unit, FEMA grants unit, reviews all invoices to ensure all work indicated is validated. On the vendor due diligence side, the challenge with onboarding a new vendor at this point mid-project is that a new vendor would accept no liability to claims that are currently submitted. Also, any new vendor would require significant rework of the documentation and supporting due diligence of the claims, which would be cost prohibitive and frankly really detrimental at this point from the reimbursement perspective from FEMA. Base Tactical has been providing FEMA consultation services at New York City Health and Hospitals since 2013 and has an understanding of all New York City Health and Hospitals facilities and damages sustained from Superstorm Sandy. Base Tactical provides strategic advisory services in regards to how New York City Health and Hospitals should approach the rebuild, mitigation of all facilities while maintaining proper reimbursement compliance with them. So finally, we're requesting to authorize New York City Health and Hospitals to enter into a 5-year best interest contract extension with Base Tactical Disaster Services for $6.8 million for the renewal of 7 years and an extension of the existing terms for 6 months for the remaining $1.4 million from the original contract. As mentioned before, the extension will be specific to the work related to Superstorm Sandy and also Hurricane Ida. The anticipated start date would be July 1st, 2022.
Great. Thank you. I will open it up for questions from the committee or comments.
Can I ask? Yeah, so the direct administrative costs are costs that we have already charged, basically, that we have. I'm trying to understand where the money left over comes from. The money that we have now that we have not spent is the money that then we can use that is not connected to any reimbursement from FEMA, therefore we can spend it for the next 6 months?
Right. So when we have basically a project under FEMA, there is a percent of that project that is allowed for a reimbursement under the administrative, so that 4% is applied to the cost of the full project. And up to that amount is basically what you're allowed to spend on the admin piece, which Base Tactical Services qualifies.
And that could be internal or external?
I'm sorry, what do you mean?
That's an administrative cost connected to grant closeouts and so on, internal and external, meaning like our expenses plus
Any of our
outside
costs.
consultants.
Right.
Okay, and why is it 1.45 million over the 6 months, but then it goes down to like 6.8 million for 7 years? Why does the amount goes down over time? Do they get paid?
So
They do, or by some retainer?
So it's based on the scale and the number of hours basically that remain for the next 7 years. It's a question I also had, but it depends on the scale and the size of the projects that are left to come in the upcoming 7 years.
So it's reasonable to assume that they have more work over the next 6 months and less work 7 years after that, right? Is that true?
So the 6 months, so the 1.4, it's more about extending the term of the existing work so we could still draw down the rest of the 1.4. So it kind of leaves the dollars at play for that 6 months term. So it's work that's, wrapping up as related to that first 2016, but the extension of the term just allows us to continue, using that 1.4 million. So that kind of relates to the old work, and then the 6.8 is the new work and new hours that they will be spending in the next 7 years. Does that make sense?
I think
It's like leftover dollars.
Yeah.
But it's always tied to the work done.
Okay.
Right?
Right,
It's always
correct.
tied to the project and the work that's done, yeah.
Yes.
So-
Jackie?
So I think I'm just unclear of when it, oh, it's not there, no, when it says dollars left, and so that dollars left go where and do what?
So you're referring to the COVID piece?
Yes.
So it's basically all it's saying is that the dollars that are spent to date, right? So some of this information we have, let's say, is as of November. I have to double check for this one. It's for, I think it's February. So that's the spend to date as of then. So what is left is what was authorized before for COVID services, right? What we've drawn down out of that is 2 million out of the 4.6 that you see. So what remains that we could spend for the rest of this fiscal year, that time frame, is the 2.5. So it's still at play, right, this fiscal year, in terms of the remaining work for COVID-19.
Right, so you
that's
could
what it
use that
means.
leftover for the, okay,
Right,
Yeah,
because
what
we're
you
still in the fiscal year, and this contract ends in June 30th,
right.
2023.
So the 1.4 of the additional extension is in addition to the 2.5 we have left here that,
So the 2.5 is related, right, so the 2.5 is specific to the COVID-19 emergency work order,
okay,
and the 1.4 is specific to Superstorm Sandy, which is the original 2016 contract that was
got it.
initiated.
So we don't, this you anticipate will be spent by June 30th, the COVID
Right, we
dollars,
should be
or
done with
spent
all-
or
whatever
not
is
used?
left. Right.
Right. And what is the cutoff date? There's a reference that FEMA has issued a cutoff date for COVID-19?
So that's our public health emergency, May 11th, right, got that right, May 11th.
So all the reimbursement requests have to
Emergency
be
work,
in
all
by
emergency.
May 11th? Is that what that means, or?
It's
Not the reimbursement request,
the
but you can't
reimbursement.
spend any money after
like the
May
new
11th.
work
For
would
for
really
COVID,
end.
that would
Right,
be
the
reimbursed.
right, nothing would be reimbursable after that day,
May 11th.
Ah,
May 11th. So if you spend money on the 12th, not reimbursable.
Got it.
mm,
And Sally had a question on this. For all of the space tactical expenses, this is how we do it. We pay first and then we wait for reimbursement from FEMA, or is that how?
For the DAC, no, if Talon is here. Not sure about the DAC piece, how different that works from the reimbursement. I'll have to get back to you on that piece.
Okay,
Just in case it's different from the rest of our reimbursement.
okay. Sorry, any more questions, Jose? Mitch, any questions?
No questions.
I think there were a couple other questions. Let me see. This is from Sally. Do we expect all the work to be completed by this time? I think there's a 2030 is when everything is expected to be completed, or?
And it may potentially go past that, but as specific to this contract extension of the 7 years, we expect the majority of the work to be done there, but it may extend past 2030.
Okay, so it's 5 years with the 2 additional years, and the
1-year
6.8 million
extensions,
covers the full 7 years, is that?
Right, the 7 years is 5 years with 2 1-year extensions.
And the dollar amount is for that whole
Yes,
period?
The full period.
Okay. And are they actually doing any contracting work, or it's more kind of on expenditures, or it's sort of, I'm not exactly clear what they do.
You wanna elaborate?
So they are essentially our FEMA experts. Okay, they help us get our reimbursables through FEMA. There's a lot of paperwork that's involved, in order to be able to access those funds. But any other contracting, architects, engineers, contractors, we process all of that in-house.
So they walk the sites, they're basically working side by side with our architects, and they provide expertise on eligibility, on reimbursement.
I see.
Right, structural work, applying for different areas of reimbursement under FEMA, which were referenced, at the start of the presentation.
Right.
The 4.6, 4.8, 4.28.
Yep.
And they have clients across the country, right? Yeah.
Exactly.
They help out a lot of varying clients across the country, which is helpful because they have knowledge about FEMA that we just don't have.
Right.
Right.
They have large catastrophic events that they're handling.
And I think it's important that the point on the continuity of maintaining their expertise so that if there are problems with the claims, I mean, this has been a long
Exactly.
That's critical.
project, and we can't lose that continuity and experience.
Tremendous amount of detail, right, that goes into these claims. And making sure that the claim is right and appropriate and all the assurances that we make, and we need to have documentation for that, so they help us with that as well.
Right. Okay, well, thank you. I think the diligence that you guys did on the extension is helpful, so appreciate that. All right, so we'll take a vote. Let me go around, propose a motion to accept the resolution. So I will ask Dr. Pagan,
Yes.
Dr. Katz,
Yes.
Roe Adams, and I vote yes as well. So the resolution has been approved for consideration by the full board. Thank you. Next is another action item for consideration. I think, Leora, you're going to read the resolution into the
I
record?
am, yes, I am.
Stop on the presentation.
Under consideration today is a resolution to authorize the New York City Health and Hospitals Corporation, the system, to contract with Coordinated Behavioral Care, CBC, to provide housing location and placement services, HLPS, for a term of 3 years with a 1-year option exercisable only by the system for an amount not to exceed $14,054,014 over the potential 4-year term. Next slide, please. Well, I'm delighted to be here today to brief you a little on Housing for Health, what our strategy is, our success to date, and our opportunity to scale our work. Housing for Health at H&H facilitates housing opportunities and supports for our patients experiencing homelessness. This is important to us because 50,000 of our patients experience homelessness, and about 22,000 are also DHS clients. On average, patients experiencing homelessness visit the ED 3 times more than you and I. Patients experiencing homelessness are also more likely to have longer inpatient stays than their housed neighbors. And of course, evidence is clear that where you live affects your health and well-being. Because of these reasons, we've established a Housing for Health program at H&H, and we have a 4-part strategy. The first one is providing housing navigation services, and that is what we'll talk to you about today. Second is funding medical respite beds, which we brought to the board in the fall. Third is funding supportive services in permanent housing. And the last is using H&H land strategically for the development of affordable and supportive housing, and those matters come to the board when we execute on ground leases. To date, nearly 500 H&H patients have been permanently housed, and over 800 patients have benefited from medical respite. Next slide, please. A little bit on background. In November, Mayor Adams came to Queens Hospital and launched Housing for Health with us at the T building there, which is a building on our land that was repurposed for affordable and supportive housing. The mayor also launched Housing Our Neighbors, a housing blueprint, and as part of that housing blueprint, creating new housing navigation supports and resources at H&H to meet patients where they are at, was part of one of the goals. Next slide, please. One patient success story I'd like to highlight is a patient, Jesus, who moved into the building on our campus. And he was a patient, or is still a patient actually, at Harlan Hospital. But at the time, he was inpatient there, and he found out about an opportunity on our campus to live in supportive housing, and our team, along with Metro Plus, provided housing supports to facilitate the access to that housing, and it's quite complicated to do that, and we're so glad he's housed. I don't think this picture does it justice, but he is less stressed, as the quote said, more relaxed, but also extremely happy and joyful. And the video's on our website, so I encourage everyone to listen to Jesus' story. Next slide, please. But generally speaking, Jesus is happy and joyful, but and that happy people are good, but we hope happier people are healthier people, and that is really what we're trending towards. And the national data shows that permanent housing reduces the use of costly acute care services for people experiencing homelessness. Our preliminary data shows similar trends, and there has been a reduction in the mean number of ED and inpatient visits post-housing. I'm going to turn it over, next slide, please. I'm going to turn it over to my colleague, Fanula Seifert, who's going to discuss the contract under consideration, explain why it's important, how it's going to help us scale, and how it's going to really improve the lives of our patients, but also help our staff navigate really complex processes. Fanula?
Thank you, Lyra. So currently we work with Referral Point to care for patients experiencing homelessness across the system. Today, when a patient care team identifies a patient experiencing homelessness and refers them to us, they're really taking on the bulk of the work of getting that patient through the housing process. So they're referring the patient, they're doing all of the paperwork for the housing process. This includes collecting vital and income documents, which you can think of as being akin to kind of the paperwork you have for a mortgage. And they're ushering the patient through that whole process of getting into the housing. This is burdensome for staff and inefficient for patients. In order to secure housing, patients experiencing homelessness really need specialized support. The New York City housing and homelessness space is incredibly complex and niche. And despite sorts of income discrimination protections, landlords often need additional assurances from partners like H&H to bring somebody who was previously experiencing homelessness into their buildings. In April 2022, with all of this in mind, we released an RFP for comprehensive housing placement services. So the scope of work reflects best practices as modeled in Health Services of LA, as well as discussions with internal stakeholders across facilities to understand staff and patient needs, and our firsthand experience doing this work facilitating housing placements. The vendor will employ a whatever it takes approach to getting our patients housed. This includes finding permanent housing opportunities, recruiting additional new housing opportunities for our patients, including supportive, affordable, and private market housing, and matching patients to that housing, supporting patients through the whole permanent housing placement process. This includes developing a permanent housing plan with a patient, working with the patient to pull together their housing packet, and managing the rent-up process of navigating into housing. The transition into housing can also be difficult, and they'll support patients to successfully transition and ensure they have what they need to succeed in their new housing. Next slide. So in the future, we'll be able to allow the referral sources and facilities to really focus on their expertise, clinical and social services, and the vendor will take on those three bodies of work. Again, identifying, securing permanent housing opportunities, supporting patients through the permanent housing process, and supporting the successful transition to housing. This will support H&H as a system to connect our homeless patients to permanent housing, including single homeless adults served by our Special Populations Initiative. Next slide. So this was a competitive RFP process. We had 4 different vendors apply, 2 rounds of scoring, and CBC was the highest rated proposer. Next slide. So a little background on coordinated behavioral care. So CBC is a nonprofit launched in 2011 as a lead health home and behavioral health IPA. Their mission is to leverage community partnerships to coordinate integrated medical and behavioral health interventions, along with an emphasis on social determinants of health to promote a healthier New York. CBC and its partner agencies have all served people experiencing homelessness for longer than 10 years, and you can see they have quite a breadth of programs supporting this population, including outpatient mental health and substance use treatment programs, at health home care management, pathway home care transitional services, ACT teams, shelters, safe havens, permanent housing, and the state-funded homeless outreach teams, SOS. CBC and their partners have a demonstrated knowledge of shelter, housing, and supportive services for people experiencing homelessness, and a real experience in facilitating permanent housing placements. They've shown through their work so far the ability to meet patients where they are at points of care and facilitate placement in housing. We have a current contract with the Office of Behavioral Health with CBC for Pathway Home, and our colleagues in Office of Behavioral Health have highly rated their performance. So for the contract, we're proposing to sign a 3-year contract with CBC with a 1-year option for renewal. The estimated average annual caseload will be 600 patients with a goal of placing 400 patients in housing per year. This is about an average cost of $5,000 per patient served. CBC and its partner agencies will be bringing in a lot of additional housing opportunities for our system and our patients. The budget can be thought of in kind of 4 major buckets. The major one is personnel, so there's a small amount of CBC program support staff, partner agencies, client-facing staff, operational cost, tenant stability cost to facilitate, again, that stable transition into housing, and then a small amount of contingency funds, which will allow us to have flexibility for innovation and program improvement. Thank you.
And
I
I read,
wanted to give just a minute's testimony to the idea of this contract. When I started in LA and I was very focused on housing, I found that there were all of these people who were connected to housing case managers but didn't have housing. And they would keep going to the same set of housing case managers who'd say, I'm sorry, we don't have any housing, or you don't have the right subsidy for the housing. And it turned out there were even people who had subsidies that they couldn't use because nobody could figure out how to get an apartment for the subsidy. And so we employed a vendor with the idea of do what it takes. All we're interested in is housing. We're not interested in your meeting with the person to talk to them about why there's no housing. We're interested in people actually getting housed. And it made a huge difference. And I know you listened to the people who knew more than I did about the program in LA. And I think this is, like LA, and maybe even more so, the New York City environment is just incredibly challenging with multiple programs and overlapping rules and things you can do and things you can't do. And it's just not a function that a good general social worker can help you with. You have to be a housing expert, and you have to take a we're going to get you housed approach. We're going to figure out what it is that has to happen, and we're going to get you housed. So I'd want to speak for the scope of the work and why I feel this is necessary to take us to the next step.
Thank you, Mitch.
So, thank you, doctor. And that, because it really is hard. It's hard for people like myself, you know, and you, so that really is hard. But one of the questions I need to know, what is the age criteria? Is it just families, or is it single? Or where do the age start? Do it start at 16, 18, or it have to be, I didn't see that.
Yeah, so we have no age restrictions on this program. It's for any patients who are receiving care at H&H. So if just a child in a family was receiving care, they'd also be eligible for the service. It's really any patient who's receiving care at H&H and experiencing homelessness would be eligible for this service.
And that's even for permanent housing?
For permanent housing. This is just for permanent housing.
This is just for, so when you say permanent housing, are you talking, what's the long term, what's the cutoff? Is it a year, is it 2 years?
everyone will get a rent we're interested in everyone getting a rent stabilized lease. This is permanent housing. They have rights. It's their apartment. They'll get a 1-year or a 2-year lease depending on the, what the owner, has. But it would be a lease in their name.
So you would be negotiating a lease with the dealing with the,
Well, hopefully we're not dealing with all the landlords, and that's why we have a vendor who can help. To date, we've been successful in getting people housed, but there are just limitations of, there's only so many hours in the day that I could talk to people. So we hopefully having someone on board to talk to owners and really understand what a patient needs. Some people need supportive housing. Some people don't need supportive housing. Some people could live in non-supportive housing, but if they have other outside supports, they'll thrive. So think of it as we want to understand what's good for the patient, where they'll thrive, and put them into the right category and help them pull together all the paperwork to get there. But the goal is for everyone to have a long-term, a permanent lease. And they're all going to come with some sort of city-funded rental subsidy, as Dr. Katz alluded to. It's quite complex in New York City, but everyone's going to come with the rental subsidy because everyone is experiencing homelessness. And
Right.
if they're entitled to a rental subsidy, they will likely have access to one through one of our sister agencies.
Very good. It's very needed. Yeah.
So I think you mentioned that we have experience with CBC. Is it doing the same sort of like hand-holding in a way, or is it different?
So the Pathway Home contract with the Office of Behavioral Health is slightly different. There's not an overlapping scope of work here. We ensure they're not under both contracts doing the same work, but it's slightly different.
So I guess I'm trying to understand, how do we know that they will be able to do all these things that we're saying that we want them to do, right?
I mean, well, that's what we had an RFP. So we scored them based on their staffing plan, their budget. They show a model that for us, it's a different model than Pathway Home. This is the goal, to what Dr. Katz says, is to find housing and get people placed in housing and negotiate all those steps in the process. And their staffing.
So they have done that for other clients, I guess? Or?
I think they're partners that the way CBC is set up, they work with a cohort of other nonprofits. And they have proven, and they've met our threshold, that they have placed people in permanent housing before. So yes.
Okay. I just wanted to make sure that they were not getting into a new line of business that they had limited experience on that. That's what I wanted to get at.
They're experienced with the population, and they have experience placing this population into housing. I think for us, we're bringing a more focused, laser-focused vision and coordinated effort to do it. So, for us, we're driving the vision forward, and they've presented to us that they can deliver for our vision.
And then how did this, so the 600 per year, right? Is that, I guess I was trying to understand, because there was a huge need, right? And I was trying to understand how that.
Sure.
Is that,
I mean, many of our patients receive services in a lot of different places. And so as one of the slides showed, I think if you go back 2 slides, we're working with a couple right now, key referral points within our system. So the Safety Net Clinic, Metro Plus, the Office of Behavioral Health, our Health Home, variety of CHWs, to get referrals in. We acknowledge it's too challenging to help every single person. That's not because we don't have high goals. We just know we want to meet patients where they're at. And if they're with us for care and they've expressed this as a need and they wish for this to be an option of a service they receive, we can supply it. And we'll see what this scale looks like and take it from there. But other people receive similar services at other points in other places in the city, but we're not here to duplicate work. We're sort of doubling down on what people need. If they trust their care provider, and the only thing the care provider could do right now, and even like an exceptional social worker, is call the shelter, feels now maybe they can refer to our team, and we can refer them to a vendor who can say, okay, you're qualified for this housing type. Okay, what are your documents that you need? And we can figure out a throughput.
so, I mean, it sounds like a great idea. I mean, I like if you take the amount that you are projecting that you'll spend per patient, and the utilization reduction, it more than pays for itself just on that alone. So it's pretty impressive. That's it.
Agreed. Thank you. So I have some questions from Sally. So I think first, just following along on some of Jose's questioning on CBC, do you have any sense of how many clients they have placed, so that they have done this actual placement of into housing?
Well, CBC works with they're sort of a consortium, and so they're bringing their placement entities. What makes it work, we're so pleased, is that New York City, a city of 8 million boroughs, 5 boroughs, you kind of need a big catchment area. And so their partner agencies all have had placements, and they all serve different niches in the market. Some is maybe SMI, some SED, some people, some groups in their consortium work better with market rate owners of housing. So the goal is to create like a breadth of options. So I don't have the numbers off the top of my head, but indeed, if Fanula has the numbers, she's the brain of the
Yeah.
operation. Here we go. Together, the four partners have placed over 2,000
Great.
people
last year.
into
In the last
housing.
year? Okay, terrific. And so presumably, having a vendor like this will help, because you guys have been doing it, however you've been doing it, I guess, picking up the phone and calling, but they have access to networks, to more potential.
And they have their own housing,
Oh, they have their own housing, actually.
right? I think that's what makes it a good
I didn't,
fit, right?
realize
They're
that.
they're a mix of supportive housing developers, supportive housing providers, service providers, plus in some cases, they have a network of, landlords that they've worked with.
right.
Um,
Do you know how many units we expect to be available over the next, what's the 3-year contract, or 4-year contract?
well, we expect them to meet our goals, so that would be 1,200.
1,200.
Yep, 400 a year, and hopefully they'll exceed them.
And I guess on the pricing, how is the pricing of the contract working? So I guess some context for how the 14 million, I know the 5,000 per patient served is kind of the cost divided by how many you expect to place, but they're not charging you based on sort of each patient served.
No, I mean, this is very staff intensive, right? So if 70% of the annual contract is going to be staffing, and 30% is going to be overhead, or providing the move-in. People will get whatever tenancy supports they need to transition. So it's not. We don't think it's outrageous to think it costs about $500 a month. And it takes about 9 months to get someone housed. It's not an instantaneous thing. I wish it was faster. I wish we can house someone in 90 days. Unfortunately, sometimes it's harder. I think as we get our systems in place, perhaps we'll pick up the pace. But I don't think it's unreasonable to think it takes about 9 months in New York City.
Frida's asking, how are you going to be invoiced?
Oh, how are we gonna be invoiced?
5,000 per person. You're going to be invoiced how?
On a monthly basis or quarterly basis, we're working out the mechanics now with our attorney on how the best way to get the invoices.
Based on their expenses, presumably, during that
Correct.
time?
Correct.
You're going to reimburse expenses, but we're anticipating an outcome.
Correct.
So, right, we would have a problem if at a certain point we had a lot of expenses, but no outcomes, nobody housed.
Correct. We have a lot of rights in this contract, and to set expectations. If we were unhappy, we could cancel it. We don't expect any of that. But yes,
Right, so-
Mitch said it better than me. Yes.
So if we're not getting on track for 400 patients to get housed, we will
We would have to
revisit,
reconsider the contract.
right, what's happening. And I noted that there's a contingency for flexibility innovation program improvement, so,
They have to ask permission before.
right, I assume you'll be heavily engaged in terms
Yes,
of
they hear from us a lot already.
what they're doing
Yes.
and being able to spend additional dollars and stuff.
I
There-
assume, I'm
Go
sorry,
ahead.
Frida, that one of the things, because I know this was occasionally an issue in LA, sometimes with someone who has a special need, say they have to have a 24-hour caretaker because of their disability, you might have to subsidize their subsidy a small amount in order to make it work. Is that an example of something?
That is a great example, Mitch,
They could.
and
So, I mean, we had this frequently in LA where the person had 1,200. We could house them for 1,300. Before the instance of this contract, they couldn't be housed. Because with the caretaker, the cheapest was 1,300 and they had 1,200. So the 1,200 gets wasted because the 1,200 is coming from the federal government and they're homeless and nobody's using the 1,200. And we would use the contract to supplement another 100. And now we're at 1,300 and now all of a sudden they're housed. So, I mean, that when I think of we'll do what it takes to house you, those are the kinds of things that a good provider figures out is that you can't just go, the typical is, I'm sorry, you know, your subsidy is only $1,200, we don't have anything available, you're homeless. Right. The
Right. You
the
find
good
ways.
provider figures out how to leverage
What you have.
what you have.
So, Leora, you did mention you guys have flexibility, so you'll be able to monitor what they're doing and seeing if we're getting the goals that we are hoping to achieve.
Indeed,
um,
yes.
Stay on top of them. There, Sally did have a question on rent. Why is there a payment of rent? Is that?
I think that's for their rental space for where they're operating out of.
Oh, I see. So
Yeah,
it's their
not rental
overhead.
subsidy for
Their
their actual physical
Okay.
space.
I think we've covered most of my questions. The only thing I was going to say is I really loved looking at the data that you guys. I'm trying to find it. That page on the impact of what providing housing means to our patients, and I think this is great information, and it'll be good to. I noted that you added that you'll be tracking as you go forward, so being able to see that, I mean, I think in this sense, the investment pays for itself over and over again. So I think it's wonderful that we have systems to be able to keep track of that. So I look forward to hearing about it and all your Housing for Health initiatives. So thank you. Any other questions or comments? So we'll go ahead and take a vote on the resolution. Jose?
Yes?
Dr. Katz?
Yes?
Jackie Rowe Adams? And I vote yes, so thank you very much.
Thank you.
We have one more resolution. Andy?
Thank you so much. So this is a resolution to authorize us to enter into new contracts with highly specialized law firms to handle our behavioral health and guardianship matters that involve a great deal of court interaction. To take you through the presentation, I'm introducing my amazing colleague, Preeti Swami, who handles these matters routinely in our office, and we've also gotten great help and support from our Senior Director of Operations, Beth Brooks, who's in the audience should such questions come up.
Good morning. So
Actually, you
for
want to-
committee,
Yeah, here we go.
so good morning. So for committee consideration, I'll read the resolution into the record. Authorizing the New York City Health and Hospitals Corporation, the system, to execute 5-year agreements with each of the 5 law firms, Abrams Fensterman LLP, Law Office of Barbara J. Burwitz, McAloon and Friedman PC, Law Offices of David Smorin PLLC, Vigorito, Barker, Patterson, Nichols, and Porter LLP, the firms, for the provision of legal representation in matters under the New York State mental hygiene law, behavioral health, and/or guardianship on behalf of the system on an as-needed basis for an initial period of 3 years with 2 one-year options to renew for an amount not to exceed $12 million over the entire potential 5-year term. Next slide, please. So this is an RFP for legal services to represent health and hospitals in 2 areas that arise under the mental hygiene law. Behavioral health covers involuntary psychiatric admissions and treatment, which is the majority of the spend considered here. And guardianship covers health and hospitals' petitions for a guardian on behalf of the patient to assist that patient with obtaining benefits and, of course, planning for appropriate discharge. Over the last 3-year contract cycle, the expense was approximately $2 million per year. We are anticipating a 20% increase based on legal fee inflation, the 5-year potential term of the agreement per firm, and an increase in volume due to city behavioral health initiatives, which have basically focused on connecting individuals in the city area to mental health services. Next slide, please. So as you can see from the numbers, we are looking at approximately $2 million per year. I do want to highlight the majority of the spend is behavioral health, which you see will approximate over 90% of the amount per year. Next slide, please. The current contracts that we're awarded were done after a 2019 RFP. This work is actively managed by the Office of Legal Affairs. We're currently using a panel of 5 firms to perform this work. To note, these 5 firms did respond to this current RFP and have been selected for the committee's consideration. For behavioral health matters, in terms of assignment, 1 firm is assigned to handle matters arising for all hospitals within a borough. Since courts are borough-based, this approach is most efficient. It essentially fosters a good relationship with the court and with the hospitals. Given the high volume and regularity of cases, we are looking at several cases per hospital per week. This approach also provides consistency for the hospital. There is one exception, which is Manhattan, where we do have 1 firm covering Bellevue and another firm covering Met and Harlem. For guardianship matters, firms are selected to represent a facility on a case-by-case basis, and we consider attorney availability and the specific issues to be addressed in the case. To note, the current contracts do expire on March 31st of this year. Next slide, please. So the minimum criteria for the firms was to have at least 2 attorneys with at least 5 years experience within the expertise, 5 years experience and expertise within the area bidded upon. So you could bid for behavioral health or guardianship or both. Next slide, please. So the substantive criteria was 60% for experience and expertise and 40% for cost. And to note, the evaluation committee comprised not only of staff, legal staff from OLA, but also clinical departments within the space of behavioral health and social work for the system. Next slide, please. So one thing to note is that the vendor diversity team did identify 3 potential MWBEs. 1 is currently providing services and ultimately became a selected vendor. The team did do outreach efforts for the other 2 firms. Of those 2, 1 did not have expertise in the area for which we're seeking, and the other expressed no interest in pursuing the RFP. There was initially no diversity vendor component percentage initially set on the solicitation, as each vendor was expected to self-perform all work. However, when the team performed its routine due diligence in reviewing the proposals, it identified a subcontracting opportunity for MWBEs, which was courier services. All firms have agreed to utilize MWBE services for, MWBE firms for these courier services. And to note, that is a significant spend of the ultimate contract value. This is essentially courier services to make sure patients are served appropriately with their papers and the papers are filed in court. And this amounts to hundreds of filings. So ultimately, the diversity or vendor component percentage has been revised, and all vendors have agreed to a 10% diversity vendor component percentage. Next slide, please. So the firms selected are currently performing services under the prior agreements, so the panel essentially would remain the same. Next slide, please. And as discussed, we're seeking approval to authorize agreements with each of the 5 firms, and ultimately it would be a start date of April 1st, a 3-year initial term with 2 one-year options, which we'd have the discretion to renew. Thank you. Are there any questions?
Actually, I'm just going to add one thing. No firm is guaranteed any work. We have an assignment process and a practice, but no firm is guaranteed any work, even if they are contracted with.
Great, thank you. Any questions from the
Yes,
committee?
I do. So security. So the vendors and do they bring their own security, or how do the security work for that?
You mean like physical security, or
Yes, like the what's that? The police security, or the security at the hospital for the behavioral health, especially.
Great question. Actually, most of the hearings now are handled remotely. So they're handled, the patient is actually at the bedside or the chair side, depending on where the patient is. So the patient is often in the clinical setting that is secure inside our hospitals for the hearings. When they are not, in some cases, the cases are in person, and historically they are much more commonly in person. The courts have security.
It's the court officers that do provide the security. At a time pre-COVID, when we were required to bring the patient to the facility for the hearing, there would be a behavioral health aide with the patient, along with, I cannot recall, it depends by hospital, there may have been HP involvement just to ensure there was no issue, but ultimately it would be the security of the, security would be provided by the court. But now what we're seeing is post-COVID, there was success in having virtual hearings, which were ultimately great for the system because it ensured the patient could remain in the hospital, receive care and services throughout the day, and not be in an unknown environment with potential stressors. And also the physicians were able to remain in the facility so they can provide treatment services and testify when needed virtually. So we're hoping to maintain that virtual system.
It was a huge issue before when doctors had to spend the whole day at a court, and then we lose the doctor on the facility. So it's very important to us that this practice remain, especially while we have such shortages of psychiatrists.
No question. I have one question from Sally. She said the minimum criteria is very modest. Can you tell us more about the number of attorneys and experience of each of the firms?
Sure. Would you like me to go through each of the firms? Because I can.
Sure.
Sure. So generally.
No names and, yeah.
Pardon?
Yeah, not-
Right. So generally, the way a firm is set up, and I can go through the bigger firms. So when we're looking at the firm setup, usually there is a partner or two. I would say one main partner who understands the behavioral health work, and under that partner, there's usually 2 to 3 senior attorneys doing the work, and below that level, there's an associate as well. And in addition, there are paralegals, which have a different rate of cost, which are there to do more of the administrative role. But ultimately, there is a senior partner who does have experience in the area of behavioral health, also has a general sense of how the courts work, because each court can be very specific as to their rules and expectations. So ultimately, there is a senior partner and associate team under them. For behavioral health, these firms are, for guardianship, the firms are smaller. So we're really looking at solo practitioners or a two attorney shop. In those cases, it's the attorney handling all of the work for the one case. But I will say for the firms providing guardianship services, we're looking at firms who have been doing this for 20 plus years, and they are basically known across the court system as to these are the type of proceedings they file on behalf of hospitals.
Okay, thank you. I don't have any other questions. Thank you very much. We'll go ahead and take a vote on the resolution. Jose?
Yes?
Mitch?
Yes.
Jackie? Yes, and the resolution has been approved for consideration by the board. Thank you very much. Next, we have a financial update.
Good afternoon. Hello. Nice to see you. Yeah, so we have our update through the midpoint of the year. I'll say that, I think the system is performing well. I'd say it's stable. $500 million in cash in January. I think we closed February with $650, and I think today I checked it's about $520 or something in that neighborhood. So we feel pretty good about our cash position. I'll also say patient care revenue is performing very well. It's not the big year-to-year increases we've seen in the past couple of years, but that's really expected that things would start to plateau. But we're still running $43 million ahead of this point last year. We'll talk a little bit more, Salima will talk about, the risk pools really helping us tremendously. And I think versus the budget, right, because the 43 is kind of a year to year, we always try to keep track of both. I think the performance there is over 190 million or something in that range. So revenue side, things look very well. Volumes have all come back, to pre-COVID levels. Collectability is good. But we are, at the end, $90 million off budgets. We're off by 1%. I think the way I look at it, and we've been, spending quite a bit of time, but I think no real big surprises for us here. I think these are some of the forces that we were anticipating, but mostly it's around, contract nurses, other contract staff, where the unit price is, significantly higher. We remain, deeply committed to the nurse staffing ratios, right? So as long as we're going to run the bed, we're going to have to put the resources there. So they're more expensive, obviously, than our own nurses, but we expect over time, that should stabilize itself. There's obviously inflationary costs. We're seeing that across the supply chain. affiliate costs the same there as well. But again, I don't think it's any different than what our colleagues in the city or even really across the country, healthcare systems have been, experiencing and grappling with, and we're just gonna have to adjust to it in the future. And I think that's our, and we'll have to work hard to do that, but I think that's the bump in the road. James will go through the financial plan. I think our year end, our estimates will miss by about 145, and James can go through, those numbers there. But the risk pool is really helped us throughout, all of COVID, that stability plus the extra revenue that it's thrown out post. On the downside of COVID here, I think has really helped us out, significantly. Strategic plan is doing well too. We're at $397 million through the second quarter and on target to hit the 675. Matt convenes a meeting with us all, and everybody is, for the most part, green and yellow. So we're going to raise the bar on ourselves. I think we still have to, do better here. But throughout all the major, different, projects we have, very many projects we have, across all of them, I think we're doing exceptionally well. So that's good. In terms of, so the next slide, I think I covered this already. Cash is doing fine. I think the next slide here is just a little bit of an overview about the state budget. They definitely have their hands full up at the state. The global cap, which is really supposed to be, budget neutral, they have over $1 billion problem to start in the global cap. So that's in what they call the scorecard. So they have to they got to solve $1 billion, right, to start, and that's really what's putting a lot of pressure, on the scorecard. In addition to that, there's safety net hospitals got a one-time payment this year of about $800 million that's not in the plan for next year, and that's going to be problematic for our safety net hospital colleagues. Doesn't directly affect us because we have our own solutions around UPL and the like, but we are watching carefully and try to be helpful to our safety net colleagues. But that's another big piece that's not in the budget. 340B is a cut that is already programmed into the budget, and if we're going to reverse course on that, that will require additional spending. So a lot on the card, but I'm confident that they will figure it out. I'd say just focusing on the negative side of the card here is the quality pools were eliminated, and I think that's not I don't think that's really who we are as a New York State Medicaid program. To carve the pharmacy benefit out, which is I think probably one of the largest components of the budget, right? To carve that out and have that handled separately by the state, and couple that without quality pools where you get rewarded for providing better care. I think those two things need to be seriously considered, and hopefully they will by the end of the budget process. On the positive side, there is a 5% Medicaid increase for both inpatient and nursing homes. The inpatient increase is actually tied to the 340B cut, so that's a little creative there. I think what they're trying to do is as they're pulling money out as associated with 340B, they are trying to put it back, to safety net hospitals and FQHCs. The second is the essential plan. There's a pretty significant increase in the hospital rates. I think it's like 225%. Of the Medicaid rate. They benchmark to the Medicaid rate. That's very generous. That will help us, but certainly not enough to cover the cost of the 340B cut, those two things together. There's $1 billion in capital transformation funds. Those are very useful dollars to all safety nets. Our ask is for there to be a set aside of the $1 billion just for safety net hospitals that have trouble accessing the capital market. We were very pleased to see that the UPL conversion authorization was extended in the legislation. It's been there for a number of years, but it's good for us. That's the tool. We'll talk a little bit more about that later today. And then there's some coverage and reimbursement expansions, all welcome. Behavioral health, in particular, and the state is really trying to be of assistance there in terms of supporting more behavioral health services. So again, I think they have a very busy next couple of weeks. The One House bills started to come out last night. We're looking at those with Deb and Michelle and folks. We're up in Albany, maybe more than we're down here at our desk here, trying to advocate and help the state find their way through, which I think again is going to be a pretty challenging couple of weeks, but I'm confident that they'll get to a better place. So with that.
Sure, I'll walk you through the next couple of slides.
So as John mentioned earlier, we ended December with a net budget variance of negative 89 million, which is a 1% negative budget variance. This is receipts coming in higher than target at 189, offset by disbursements coming in also higher than target at 278. I'll go through the variance drivers on the next slide. So for the revenue, the big ticket item there, as you can see in the chart, is 164 million to the positive, coming from our risk pool performance. That's primarily due to our per member per month excess medical revenue coming in higher than we anticipated in the budget. We also did have a little bit of prior year reconciliations that also hit the cash this year. About 23% of the variance is coming from that. On inpatient and outpatient volume, we're tracking pretty close to target. Discharges are slightly below target, but the losses are offset by improved rates and cash collections. PACs are doing better than target as usual. And then we also have a slight decrease in our miscellaneous revenue, mostly 340B. We'll go to expense. So as John mentioned earlier, our expense variance drivers are attributable to a couple of things. One is we still do have some COVID disbursements hitting the cash this year, $60 million year to date. But the big ticket item there is the agency patient care temp staffing coverage at $179 million over target. And again, that has to do with a combination of the utilization as we come off of COVID and we get back to our new base level setting with hiring up. On the permanent H&H side, we are utilizing temps, and also the rate differential between what's budgeted and what the actual right sourcing rates are now. It's driving a variance. I'll pause there.
That part is improving in real time. Because so much of this reflects the triple pandemic of the COVID, the RSV, the flu, and the pent-up demand. And census is down throughout compared to those peaks. And so we've been pushing down the rate of use of temporary staffing, which is what's so expensive for us. So in general, you would think that increased census would be taken care of by increased revenue. And it would if we didn't have to rely on temp staffing. But when we have to rely on temp staffing, it blows it out because the temp staffing is so expensive. And yet, when we're full, we really have no choice because we run trauma centers. We can't just close them down and say, I'm sorry, we're full. So the increase had no choice but to staff up and pay what's available. We're hopeful that especially if the city comes up with a fair payment to NISNA in the new contract, that we can then really push down our reliance on temporary staffing and hire up permanent staffing, in which case if we had enough permanent staffing, then we could deal with ups and downs of census without producing deficit.
This last slide just illustrates, to John's point earlier, the year-over-year changes in revenue. So as you can see, our inpatient and outpatient billing revenue is 42.6 million higher than FY22. Again, it can be attributable to a number of things, combination of higher volume, on the outpatient side, particularly not on the inpatient side, solid performance and continued improvements in rev cycle and other strategic initiatives. CMI, and that's just the illustration of discharges versus last year, and CMI.
Hi, good afternoon. I'm Allison Hartman from Revenue Cycle Services at Health and Hospitals. Just wanted to provide an update to this group around how H&H intends to be as prepared as possible, really, to address our patients' needs recertifying for Medicaid. So just by way of a little bit of background, I think folks are familiar that for patients enrolled in Medicaid,
They've been renewed automatically without being required to go through that normal annual recertification process since the start of the public health emergency. During that period of time, our Metro Plus Health membership and Health First membership have grown really dramatically, so by over 100,000 and 14,000 members respectively, in line with the overall increases in Medicaid enrollment statewide and across New York City. We did receive guidance recently that the Medicaid recertification requirements are going to go back into effect. Really starting with Medicaid application rules, returning to normal rules on March 31st. And then really cohort by cohort, Medicaid members will start being due for recertification beginning July 1st. So the first set of renewal notices are expected to go out April 1st. As these requirements start to be phased back in, we do want to make sure that we are as prepared as possible and can really help our patients who are Medicaid recipients maintain that coverage wherever possible. Next slide, please. I just wanted to provide some highlights from our overall strategy. We've been looking to really develop and then implement strategies both on our own as well as with our managed care partners. That includes communications to our patients. We're looking at multiple opportunities to communicate across different means to make sure that there's strong awareness across our communities, including by mail, flyers, emails, texts, and MyChart messages, as well as updates to our website. We're also looking to do proactive outreach to our patients who may need recertification assistance, not really rely on folks to have to take that effort upon themselves. We're looking to coordinate between our central telephonic financial counseling team as well as facility-based financial counselors across our hospitals, and really leverage any existing interactions we have with patients. So looking at whether it's at the point of scheduling, when patients present to our clinics, interactions the care team may have with patients, as well as our community health workers, and really look to leverage those interactions and offer assistance wherever possible. We're looking to take a consistent approach regardless of the plan that the individual has their Medicaid coverage through, and looking to monitor our success throughout this process. We also just wanted to share some highlights from Metro Plus's strategy, which we're working very collaboratively with them. Will include really town halls and sessions to raise awareness throughout communities. They're looking to implement concierge programs at our facilities. They're also looking to communicate really in partnership with us to raise good awareness, partnering with CVS for when their members refill their prescriptions, to provide communications at that point, as well as working with us to do that proactive outreach to their members. Happy to take any questions.
It's probably worth, in terms of all of our expectations, understanding that some people will not be reachable, but some people who will be reachable will no longer be eligible. So no one should have expectations that, right, because what happens, right, if you stop checking for eligibility, then everybody stays eligible.
Right.
But if you start asking eligibility, it will turn out some people are no longer eligible, right, because of income or other factors. So whatever the number is, it will drop. It's just a question of how far it drops and how successful we are at maintaining those people who are still eligible in the program.
Yeah, I would say, Mitch, I think, Health First, Metro Plus, also grappling with the same sort of analytics, like how many people will leave and then in what category, right? Because everybody's expecting Medicaid will drop off, but if we could capture people in EP, as an example, right,
Sure.
where the rate is actually much more generous, right, perhaps we can break even here in terms of the dollar value.
Right.
No doubt people will leave, but it's capturing as many as we can and putting them in the right benefit package for them, which is where I think the opportunity is.
Sally actually had a question on this. She made a statement, 50,000 Medicaid members are expected to be recertified each month. I'm not sure if that's what Metro Health Plus is.
That's across all of Metro Plus's membership.
Okay,
So our patients and other patients that
And-
Metro Plus
I
has
see.
with other people.
Um,
It's a large number regardless. even-
Right. And she said, in our financial projections, how much revenue and how many patients do we project losing with Medicaid recertification?
Where'd Selima- I think, is Selima still here? Yeah, I think in our plan for next year, we're assuming that we'll return back to the pre-COVID state. And we forecasted that there will be a drop in the risk pool. So we are taking a pretty conservative position to start until we see how this sorts itself out.
Okay.
But that's all part of our plan for next year as we're trying to sort through. And we're, using the intelligence from Metro Plus and Health First to help inform our estimates. There's Selima, did I get it right? For next year on the risk pools, what did we assume?
For calendar year '24?
Yeah, things will flatten out, is that?
Yeah, I mean, because we get paid on a 6-month lag, we won't necessarily see a big impact from from the volume, from the Medicaid recertification coming back on until like the last quarter. But we are working with Matt's team to come up with what we think the per member per month will be, what we think the excess medical revenue will be, and what we think the enrollment will be.
Everybody's trying to sort this out, and this dynamic between the overall drop in Medicaid and the shift over to EP is the big financial lever, right?
Right.
How many people can you actually get the shift over to EP, because the rate, again, is just so much more generous than Medicaid.
Yeah. So it may not be as a pure loss.
Yeah.
John, did the state ever resolve the issue of undocumented persons over the age of 65?
They're still working on that. In last year's budget, they reserved, I think, almost $230 million, a sizable amount of money, right, to take care of the undocumented. What's in the proposal for this year is that program goes away, but they're trying to access and use the essential plan, right, as a means to ensure the undocumented through another type of federal waiver. I think they believe, they're optimistic. But we certainly, that's an important piece of language and program for us.
So in that instance, if they succeeded, all undocumented, not just those over 65, would be able to enroll in the essential plan.
I'm not sure if they're starting with the 65. Is that, yeah, they're starting with the 65. I think it's just a switch over to the.
I see. So they're not including everyone,
Right.
but there is a proposal to include everyone. I've heard.
Senator Rivera and others have
Right.
long championed that, yes.
Right. But what's in the state budget, we think, is offering
Yep.
those over 65
Yes.
to join the essential plan.
Exactly.
And would the premiums be sufficiently affordable that people would be able to do it?
Yes. Yeah, I think, one of the advantages of New York State being an essential plan state is that there's a big reserve of federal dollars that's in your accounts. And I think what they're really trying to do is, use those dollars appropriately and try to cover, those, starting with those that are over 65.
There are different tiers of the essential plan. Some have very, very low premiums per month, literally zero. The higher ones, it could be a challenge for some folks, but we'll have to just watch it.
Jackie, we can ask something?
Yeah, because I'm really concerned about this. You mentioned it earlier about some will not be reachable. And this is some serious stuff here when you talk about Medicaid, because everybody, almost the world, rely on Medicaid. And so the ones that are not reachable, what do we do? How could they?
Well, we're very fortunate to receive a lot of what we call disproportionate share dollars. Health and Hospitals enjoys about $1.3 billion, $1.4 billion of those dollars, and those are our safety net of the safety net dollars. So when people actually are deemed, not insured, right, and we have to cover the cost of their care, we use the DISH program as a means, to reimburse for that care. But obviously, it's very powerful for somebody to have an insurance card, right, that they can call their own.
Yeah.
And be able to seek, services when they need it. And I think that's what the state's trying to do by accessing the essential.
And that's the concern. And the doctor asked a question about the undocumented. I was going to ask that, too. but you did sort of kind of answer that. But yeah, it's very serious that the message get out. The message get out, and I heard who you're partnering with, and a lot of people do go to CVS, and I just hope that they let. I've been telling, because I got it, I heard it early on. I've been speaking to people and making calls myself, saying if you get your renewal in the mail or whatever you get, pay attention. Pay attention. So it's going to take all of us to really get the message out there on this Medicaid piece. And I'm glad to hear that if undocumented and the ones that are not reachable, that don't want to answer their phone or open their mailbox, and this happens. So I just, so.
Yeah, thank you.
Great, thanks. Think we've got 10 minutes, so we want to make sure we get through.
Okay, I'll go
PPP.
quickly.
Not too quickly, it's a good discussion.
This
Thanks.
slide is just a snapshot of a little bit of what we've talked about, how much our value-based risk lines of business have grown since 2020. As you see, 160,000, 25% increase. So these are individuals who have gotten covered with our key value-based partners and are driving some of that risk pool earnings that we talked about. And so the next slides talk a little bit about what our goals are in these value-based arrangements, how we're driving some of that risk surplus growth you've seen. Obviously, the enrollment growth is the major driver of the risk surplus. The more people you have, the more opportunity to generate surplus you have. But some of the key strategies that we have underneath that are to make sure we're getting accurate premium revenue, accurate per member per month payments per each of those individuals. So we do that by trying to adequately document the complexity of their care, what they need, and what care we are managing for them. Some of the key areas that we see big opportunity in our system and we're working hard on are some of the social drivers of health, the social determinants of health, new Z codes that you chart when a person has unstable housing, doesn't have access to food. That's a relevant part of their healthcare needs and can be coded and built into the risk adjustment. We have a lot more opportunity to do that as our patients do have a lot of social needs that we haven't historically captured in their medical records. So working hard on that. Lots of opportunity in asthma. It's a place where individuals get kind of emergency care, but then do not have the kind of ongoing management that we'd like them to have. So we were working on that with many of our facilities and many of our patients. Bringing in members who have not used care recently. One of the key kind of mentality changes in value-based payment is that you're caring for patients even if they don't show up in the clinic on that day for care. It's about managing a panel and a population of patients. And so if people haven't come in a while, it may not mean that they're doing great and everything is perfect. It may mean they just need a touch and some engagement to come back in. And that has financial implications for our work as well. And then I think the biggest on this side is patient satisfaction scores. Correctly so, the federal government and others are more heavily weighting the satisfaction that patients have with their care experience, how easy it is for them to access care. And so the better we score on those things, the more financial returns we'll be able to have in our value-based relationships, and we're working hard on that. And then the second, I'd say, big area of work is in value-based payment is always shrinking unnecessary utilization and being more efficient. And we're working on that with a lot of these programs to help our patients who have the most challenging situations have better health outcomes. And the housing navigation contract that you saw earlier in this session is one of those types of investments that we're making. On the next slide, we have a quick snapshot of some of the work we've done on our quality scores in both Health First and Metro Plus. The first chart on the upper left is just an indication that Health and Hospitals historically has performed meaningfully better than private hospitals and private healthcare providers who are in Metro Plus's network. 20 to 33% of our quality scores are over the 90th percentile of how everyone is counted, and many of the community providers in Metro Plus's network don't have any quality scores that reach above the 90th percentile. So we're very pleased with that, and to show how even with our challenging situations, the scale of our network, the scale of our facilities, we're able to drive that really market-leading quality performance. And then with Health First, a couple of key things that they track and we watch with them, our overall quality rating with them has steadily crept up over the last 4 years. And we are a big part of their network as well, and so we're working hard to help push them up back to a 4-star plus Medicare plan, and to raise the whole plan's quality scores this year. And so on the next slide, just a couple of key takeaways on our biggest value-based payment goals this year. We have many, as you heard me ramble on about here, but the two, I'd say, biggest ones are to successfully partner with Allison's team and with our health plan partners to recertify as many of those members as possible. Right? We managing their care, driving that risk surplus is only possible if they remain enrolled, and so we're working very hard to do that. And then I think this area around patient satisfaction scores, access to care, will be another big area of focus for us this year. We have work streams in place on really everything else we've talked about, and these are the two areas that require, I'd say, the most focused attention this year and present the most opportunity for us. So that's where we will be pushing ahead, and happy to take any questions.
I was trying to get a sense of the magnitude of the potential resource that we get from focusing on the access to quality measures that you were mentioning there, doing HCAHPS and all of that.
Mm-hmm.
What are we talking about when we look at 2023 and say?
It's difficult to project because it becomes factored into an overall risk adjustment formula, as you know, but it is, I would say easily, it's tens of millions of dollars a year for us. And that scale of opportunity is very meaningful. Where it fits in with all the other things we're working on, I put it right at the top of the list with every other piece of work. Of course, one of the hardest to drive and change, right? Completing documentation, supplemental chart review, that is relatively easy compared to opening up ambulatory care access in a way and improving patients' perception of the quality of their care. But it's really what we're all here for and the goal of it. And so you have to, we can quibble on some of the edges of how CMS and others are trying to factor it in, but as a direction for where the healthcare system should go, you have to say it is the right thing. You would rather judge on how patients are feeling about their care than on, some other documentation minutia. It's a meaningful one.
I think it'll be interesting to learn more about what drives those perceptions, like in either from internal data that we have or from what other systems experiences. I'm not sure, but anyway, just something to keep in mind.
No, absolutely will. I mean, I think we are happy to come back with it. The challenge, of course, is everybody complains about HCAHPS and says they're not accurate, the sample sizes are too small, it's too difficult, but nobody has a better solution at all. And I think people struggle with it, but it is, the best research I've seen on it is that it is really end-to-end, right? It is like the window washer at the hospital being one of the most important people, right? Are you greeted in a friendly way at any level by staff? And then I think the ultimate one is, do you have any kind of personal connection with your physician? Is that level of personal engagement there at any point in the journey? Those are big things. And those are the two that I've seen pulled out, but there's going to be more and more work on this, published on it, and learned about it, and we will share our findings as well.
Thanks.
Sounds like that has the greatest opportunity for change and learning, so exciting to hear about it. Thank you, Matt. And James, I think.
Yes, I know we're at time, so I can go very quickly just to provide a quick summary of the January 24 financial plan that we released in conjunction with the city last month in mid-February. I'd say our plan is relatively consistent with what we've done in the previous years. There is a slight downward adjustment this year and next year to many of the things John talked about earlier in terms of some of our temporary staff costs and other inflationary type costs that sort of drive of our expenses that is also coupled with in fiscal years 23 and 24 some delays that we're expecting on some of our federal revenue streams. And so as a result, we are projecting a small negative overall margin in fiscal years 23 and 24. We do expect that to rebound by fiscal 25 as we kind of catch up on those payments and our expense structure stabilizes. And then as we get into the later out years, as has been the case for a few years now, we are facing the full brunt of DSH cuts. So the DSH cuts that are at the federal level will begin without a further delay or repeal October 1st of 2023. So we're facing 4 years of DSH cuts in the plan. Those cuts are about $600 million per year. We do want to advocate.
600.
Yes. We do want to continue to advocate for a delay, but we currently have strategic initiatives in place with growth growing from 1.1 billion this year to 2 billion by FY27 to sort of stabilize our situation. And just an important note with those DSH cuts, if they were to be delayed and we were able to sort of adjust our strategic initiatives downward, we'd about break even in those out years. So our plan would look relatively balanced across the full 5 years. Given that we're at time, I can pause there and just see if there are any questions.
Any questions? Members? No. Okay, thank you. Thank you for the whole team for a really great comprehensive report, a lot of great work being done. Is there any old business? No, any new business? There being no further discussion, the meeting's adjourned. Thanks, everyone.
Thank you.